Welcome to my TED Talk. My name is Taryn Niemeyer. Let's start with a story. Meet Sarah, a 28-year-old office manager who enjoys spending time with her husband and dog. She and her husband are ready to start a family and have been trying to conceive for over a year with no success. She visits the clinic with concerns about fertility. When asked about her past medical history, she reports a history of acne, which was diagnosed and treated in her early 20s. At that time, she completed isotretinoin therapy and then continued an oral contraceptive and spironolactone for 5 years. She stopped taking both medications over a year and a half ago to try to start a family. After stopping the medications, Sarah noticed her periods became irregular, her acne returned, she started growing hair on her upper lip and chin, and she began to gain weight. Sarah doesn't know it yet, but the root cause of her symptoms is PCOS. And PCOS is the topic of my TED Talk, so let's dive in. What is PCOS? PCOS is characterized as a dysfunction of the hypothalamic pituitary ovarian axis, or HPO axis, and metabolic disturbances. Normally, the hypothalamus releases pulsatile gonadotropin releasing hormone, GnRH, stimulating the pituitary to secrete luteinizing hormone, LH, and follicle stimulating hormone, FSH. In the ovaries, LH triggers theca cells to produce androgens, which FSH and aromatase then convert into estrogen. Regulation occurs via feedback loops. Initially, negative feedback limits FSH to select a dominant follicle, but rising estrogen eventually triggers positive feedback. This creates a massive LH surge that facilitates ovulation. Post-ovulation, the corpus luteum produces progesterone, inducing a normal menstrual period. Now that we know what normal is, let's look at the dysfunction of PCOS. First, the hypothalamus produces rapid pulses of GnRH, which leads the anterior pituitary to produce excess LH relative to FSH. The relative LH to FSH ratio rises to above 2:1, causing the ovaries to produce excess androgens while preventing the development of a dominant follicle. There is not enough FSH to convert all the androgens into estrogen. Low estrogen levels create an abnormal feedback with no LH and FSH surge to trigger ovulation. The failure of a dominant follicle to develop and ovulate leads to the characteristic polycystic ovarian morphology. Numerous small follicles accumulate in the ovary but fail to mature or release an egg. And without ovulation, there is no progesterone production to oppose estrogen and start menstrual bleeding. What about the metabolic disturbances? Unfortunately, insulin resistance and hyperinsulinemia also increase androgen levels in PCOS. In PCOS, insulin resistance in peripheral tissue leads to increased insulin production and release by the pancreas to compensate for that resistance. High insulin levels act synergistically with LH to further stimulate theca cell androgen production. In the liver, insulin and excess androgens suppress sex hormone binding globulin, or SHBG. Since SHBG normally binds to testosterone, which is an androgen, low levels of SHBG increase free androgens in the blood. The exact underlying cause of PCOS is unknown. However, it is considered multifactorial, with environmental influence that interacts with genetic susceptibility. The estimated heritability of PCOS is 70%, meaning the syndrome clusters within families affecting first-degree relatives. Environmental factors during fetal development also play a significant role. Evidence suggests that exposure to excess androgens in the womb may impact PCOS development later in life. Risk factors for PCOS include women of reproductive age, first-degree relatives with PCOS, obesity, high sugar intake, and living a sedentary lifestyle with lack of exercise. How common is PCOS? Sarah is not alone in this disorder. In fact, PCOS is the most common hormone disorder affecting females of reproductive age. It is the leading cause of infertility in females, and according to Hoffman et al. In 2020, its prevalence is estimated to be between 6 and 16% among women. Let's visit Sarah again in the clinic as we gather a pertinent medical history. We ask her about her menstrual cycle. How many periods has she had in the last year? If she has periods, how long do they last? How is her bleeding? Is she having pain? Does she have acne or hair growth on her face, back, or chest? Has she noticed hair thinning or balding? How much weight has she gained? Does she exercise? What does her diet look like? Did her mother or sisters have PCOS, similar symptoms, or fertility troubles? How is her mood? Does she have any feelings of depression or anxiety? To diagnose Sarah with PCOS, she must meet at least 2 of the 3 Rotterdam criteria. The first criterion is oligoovulation, which means fewer than 9 periods a year, or anovulation, meaning no menstrual periods. The second is hyperandrogenism, which can be identified by clinical signs such as hirsutism or acne, or by an elevated serum androgen level. The third criterion is polycystic ovarian morphology, or PCOM, identified via a transvaginal ultrasound. PCOM criteria include the presence of 20 or more follicles in either ovary or an ovarian volume greater than 10 milliliters. She reports only 6 periods in the last year, has visible signs of hirsutism and acne, and shows an elevated testosterone level. Therefore, after ruling out common differentials, she is diagnosed with PCOS without requiring an ultrasound. To rule out other conditions, she has had tests for TSH, prolactin, and early morning 17-hydroxyprogesterone, all of which are normal, ruling out thyroid dysfunction, hyperprolactemia, and non-classic congenital androgen hyperplasia. Although Sarah is diagnosed with PCOS, tests continue. She requires further screening due to cardiometabolic risks. An oral glucose tolerance test shows impaired glucose tolerance. Her fasting lipid profile is within normal limits, and she is screened for anxiety and depression. Her blood pressure and BMI are monitored regularly. What complications is Sarah at risk for? She is at risk for reproductive and pregnancy complications such as infertility, miscarriage, gestational diabetes, preeclampsia, preterm birth with macrosomia or large birth weight. She has tested for metabolic and cardiovascular complications, which include type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, and obesity. Lack of progesterone can cause thickening of the uterine lining from unopposed estrogen, placing Sarah at risk for endometrial hyperplasia and endometrial cancer. Other complications include obstructive sleep apnea, liver disease, depression, anxiety, eating disorders, and dermatological issues like skin tags and acanthosis nigricans, which are dark velvety skin patches in the underarms and groin. It is time to start treatment with Sarah. PCOS treatment is highly individualized depending on the patient's specific goals, such as symptom management or achieving pregnancy. While there is currently no cure, treatment focuses on relieving symptoms and preventing long-term complications. Lifestyle changes are important and considered first line for individuals who are overweight or obese. The goal is to lose 5 to 10% of total body weight, reduce blood pressure, and improve insulin sensitivity. These lifestyle changes of weight loss, exercise, and a healthy diet can restore ovulation in many PCOS patients. Medication management includes combined oral contraceptive pills, which manage irregular cycles by inducing regular withdrawal bleeding, lowering androgen levels, and thinning the uterine lining to protect against endometrial cancer. Progesterone therapy also improves endometrial protection, but does not treat hyperandrogenism. Anti-androgens like spironolactone or finasteride can be given with an oral contraceptive to improve hirsutism and acne. Sarah knows these medications will not work for her, as she wants to achieve pregnancy with treatment, but she realizes she was inadvertently being treated for PCOS with the same medications she was given to treat her acne. Other medications that are reserved for patients with impaired glucose tolerance include metformin and GLP-1 receptor agonists if the patient was unable to lose weight with lifestyle modifications alone. Let's move on to the fertility options Sarah is interested in. Fertility options include medications that induce ovulation, such as letrozole, which is the first-line medication, and clomphene citrate, an alternative. However, the first line is lifestyle changes and pre-treatment weight loss. Sarah chooses to make lifestyle changes as she doesn't currently exercise and admits she does not have the healthiest diet. In conclusion, I'd like to leave you with 3 important takeaways. I want you to remember that women with PCOS do not need polycystic ovarian morphology to be diagnosed. Second, many women with PCOS can achieve normal ovulation and the ability to conceive with lifestyle changes like diet, exercise, and weight loss. Lastly, treatment is individualized, so inquire about the patient's goals and tailor to meet them. Thank you for listening to my TED Talk.